This case involves a 68-year-old man with stage 3A esophageal adenocarcinoma, status post esophagectomy, and gastric pull-up, who presented 2 months later with dysphagia. He was found to have a severe 6 mm stricture at the esophagogastric anastomosis. Weekly dilations were performed up to 45 French with a wire-guided bougie dilator. The patient would experience relief of dysphagia for only 2 to 3 days, and the luminal diameter on repeat endoscopy was consistently 9 mm. Despite weekly dilations over 6 weeks and 3 steroid injections, the patient was unable to maintain an acceptable luminal diameter to relieve his symptoms. A 9 mm stricture was identified, and the endoscope could not pass through. An insulated tip knife was advanced through the endoscope. There appeared to be a thickened rim of mucosa with suspected submucosal fibrosis at the 6 to 9 o'clock orientation. After thorough evaluation of the stricture, a small incision is made into the mucosal layer, exposing the submucosa using the endocut setting on the electrosurgical generator. Next, 2 more incisions are made to the depth of approximately 2 mm, ensuring that each incision is within the 6 to 9 o'clock orientation. Each incision was made to the depth of the apparent extent of the submucosal fibrosis. The knife is then traced, connecting the incisions to dissect out the submucosal fibrosis. The insulated tip knife offers the advantage of careful dissection in a radial motion parallel to the submucosal layer. Additional dissection is carried out after brief inspection showing residual submucosal fibrosis near the 6 o'clock orientation. On final evaluation, there does not appear to be any injury to the deep esophageal layers. Following stricturoplasty, a through-the-scope balloon dilator was inserted and stricture was dilated to 15 mm, in order to allow for radial disruption of the entire stricture. The segment is once again carefully inspected, demonstrating adequate disruption of the stricture. Three months later, the patient was experiencing recurrent dysphagia despite an adequate luminal diameter. Barium esophagram showed a perianastomotic diverticulum with pooling of contrast. This was confirmed on endoscopic examination with the presence of a diverticular septum. The decision was made to perform a diverticular septotomy. The base of the septum was marked with snare tip to help guide the depth of dissection. Then, a scissors-type electrosurgical knife is inserted through the working channel of the endoscope and used to grasp the proximal end of the septum. An initial incision is made using the endocut setting on the electrosurgical generator. After initial incision, a white layer of thick mucosal fibrosis is exposed. The scissor knife is then inserted into the deeper portion of the fibrotic septum, and additional dissection is carried out. This process is repeated until the dissection has been carried out to the base of the septum with a goal of creating a single continuous lumen. Follow-up EGD 6 months later revealed a widely patent anastomosis with a luminal diameter measuring 16 mm. There was resolution of the perianastomotic diverticulum without evidence of recurrence. The patient was able to tolerate a regular diet without any further dysphagia. The clinical implications of the case are severe submucosal fibrosis in an anastomotic stricture may preclude successful esophageal dilation, and diverticulum formation may occur after repeated dilations due to submucosal fibrosis and pressure fluctuation in the esophagus. In conclusion, endoscopic incisional therapy can be considered for esophageal strictures refractory to repetitive endoscopic dilations and steroid injection. Perianastomotic diverticula can be successfully treated with endoscopic septotomy.